Anesthesia. Over to Dr. Risha from your hospital. Dr. Risha,
Your
yeah, your
mic,
mic is on.
Risha, your mic is,
Hello, yes, sir.
yeah, unmute.
Thank you, sir. Good evening, sir. Today my topic is about the arrhythmias intro. Arrhythmias, these are accelerated, slowed or irregular heart rate caused by abnormalities in electrical impulses of myocardium. During surgery are actually life-threatening malignant arrhythmias with severe hemodynamic instability and serious collapse. So, mechanisms of intraarrhythmias, either it can be injury to the cardiac conduction system directly or the reentrant which precipitating the wide ventricular and ventricular arrhythmias and automatization of atrial and ventricular muscle sets during the action potentials. This can precipitate arrhythmias. And further, there can be mutation of the ion channels and ectopic foci. The factors contributing to these arrhythmias is divided into patient factors, patient-related, surgery-related, and anesthesia-related. Patient-related factors that can be pre-existing cardiac diseases, ischemic heart disease, thyrotoxicosis, cerebrovascular uh, also in patients with increased sympathetic activity, electrolyte imbalance, etc. Surgery related, it can be either.
Go ahead, go ahead.
Yes, surgery related to non-cardiac surgery. In cardiac surgery, there will be an intracardiac manipulation, and in non-cardiac surgery, there can be an ocular cardiac effects or laparoscopic surgeries, the shift of vitals during the peritoneum phase, and in some neurosurgeries, and abdominal stimulation like cervical dilatation, anal dilatation, etc., and intestinal traction stuff. There can be an inadequate plane of depth, direct laryngoscopy and intubation, local anesthetics, and usage of halogen and mechanical irritants, which can be due to the insertion of central venous lines, PA catheters, and ICT tubes. And also the 4H and 4Ts, hypoxia, hypovolemia, hypo or hyperkalemias, then hypothermia and metabolic disturbances. And the 4Ts like tension pneumothorax, cardiac tamponade, toxins, and diagnostic evaluation. Ideally, we can assess the airway breathing and surgery. We need to check any drug error or drug interactions like depth of anesthesia, and also we need to check for the surgery like any vagal stimulation is involved or any air or fat embolism has occurred, hemorrhage, massive hemorrhage, hypovolemia, or hemorrhage injections. If that is so, we can also ask for a 12-lead ECG, and we can do a 12-lead ECG, and we can try to correct the cause. And we also can tell for a minimal surgical manipulation and can correct the depth of anesthesia. We need to eliminate possible causes and attempt to correct them while continuing to evaluate for the arrhythmia. About the classification of arrhythmias, there can be bradyarrhythmias and tachyarrhythmias. This can be a sinus arrhythmia and sinus bradycardias, and second defects like AV blocks, first degree, second degree, and third degree AV blocks, and intraventricular blocks like RBBB, LBBB, fascicular blocks, bifascicular, trifascicular blocks. In tachyarrhythmias, it can be a sinus tachycardia, supraventricular arrhythmias, which involves premature atrial contractions, paroxysmal supraventricular tachycardia, atrial flutter, atrial fibrillations, and in ventricular arrhythmias, which includes or 60 pointers. We'll discuss as a narrow complex arrhythmias and wide complex arrhythmias. Coming to narrow complex, sinus arrhythmias usually present in young and fit individuals, and these are usually benign. They present with a normal PR interval, but with an irregularly spaced RR interval, and alternate with a respiration, which is usually benign. And in sinus bradycardia, here it is a sinus rhythm with a PQRST complex and the morphology, but the rate is less than 60 beats per minute, and this is more common in the athletes patients with high vagal tone. About the management, ask for the worstful cause. You can give atropine up to 20 mics per kg IV can be given as a bolus, and a glyco is 10 mics per kg IV. If resistant to atropine, we can go for adrenaline or isoprenoline infusion microgram per minute. And pacing can be temporary pacing can be done if it is a resistant bradycardias. And few atrial ectopics followed by a atrial process also present. Here it is a regular QRS complex with specific 0.12 seconds and rate of more than 100 beats per minute. Yes, here tachycardias impulses can be from a sinusoidal mode or from the myocardium or from the atrioventricular junctional regions, which can be either a reinfant or a junctional ectopic. ECGs, in atrial tachycardia, we usually have a abnormal shape often outnumbering the QRS complexes. In multifocal atrial tachycardias, we have 3 or more PV morphologies with the irregular QRS complexes, which is usually common in smokers and COPD. Junctional tachycardia, here the rate is in between like 150 beats per minute, with the PVs either buried or closely following a QRS complex. Management is it can be divided as two. Either the patient is hemodynamically stable or unstable. If the patient is hemodynamically unstable, immediate synchronized DC cardioversion for the 200 joules can be given. This can be increased to 2 shots at 3 refractory. If the patient is, we can sedate the patients with benzodiazepines or mild analgesics, and we can give sinus massage. What it does is it activates the baroreceptors in carotid sinus within the internal carotid artery and increases the vagal activity and transient AV brog. And Valsalva manual can also be used. Then for drugs, adenosine 6 milligram IV bolus fast push with a flush of 20 ml normal saline can be given. This blocks the AV conduction and slows the heart rate, ventricular rate, cardioverting a junctional to a sinus rhythm, or it terminates the re-entry SVT. 12 milligram if extra dose. 12 milligram can be given if it is refractory and if extra dose is needed with an interval of 1 minute apart. The side effects of adenosine is headache, flushing, chest tightness, dizziness, and dyspnea. This adenosine should be used never should be given in a type pyramidal patients. This can cause a severe myocardial depression in patients in asthmatic patients. Other drugs like beta blockers, verapamil of 5 to 10 milligram IV over 2 minutes can also be given. Amiodarone 300 milligram IV over followed by infusion of 900 milligram in 23 hours can be given. And here the electric re-entry into atria with a rate of more than 300 beats per minute and ventricles of more than 150 beats per minute, which is like a 2:1, 3:1 ratios with a sawtooth pattern in ECGs. A similar management like if the patient is unstable, we can go for.
Go ahead, doctor.
Yes, sir. We can go for a synchronized DC cardioversion. If it's stable, we can give a carotid sinus massage.
என்னோட
We can. most common dysarrhythmias in top is atrial fibrillation. This is an independent and uncoordinated atrial electrical activity at a rate of 120 to 180 beats per minute. Here there will be a reduced ventricular filling and cardiac output. So there will be fall in the hemodynamic status and ischemia occurs. ECG, we can see a irregular pulse, and JVP, there will be no A wave or X visit due to the lack of atrial relaxation. When we palpate, we have a discrepancy in the apical and the radial pulse. Management of atrial fibrillation can be divided into two. Either it is less than 48 hours or more than 48 hours. If the AF is less than 48 hours, we can try to correct the correctable causes. Amiodarone 300 milligram IV over 1 hour should be need to be given in either a centerline or a wide bore IV cannula, and 900 milligram over for rate control can be given. We also can add beta blockers and digoxin of 500 mics IV over 20 minutes, which can be repeated in 4 to 8 hours, can be given. Since flectin per kg maximum to 150 milligram IV over 30 minutes can be given with a cardiac monitoring, which is best. Used in patients with structural or ischemic heart diseases. If unstable, we can go for a synchronized DC cardioversion. If the AF is more than 48 hours, there will be an increased risk. So these patients should be started on anticoagulants. We also can add on with beta blockers, amiodarone or verapamil 5 to 10 milligram IV, and digoxin also can be used. In chronic AF, we need to look for the preoperative rate control, which is less than 100 beats per minute. So this can allow time for ventricular filling and perfusion. These chronic AF patients will also be on the either beta blockers or amiodarone. And coming to sick sinus syndrome, this can be either familial, congenital, rheumatic, or ischemic, hypertensive etiology. ECG, it usually alters with brady or tachy syndrome, and this is usually a resistant bradycardia with atropine, which is a hallmark of sick sinus syndrome. Features of sick sinus syndrome can be syncope, dizziness, spells, pulmonary edema, paralysis, and fatigue. If unstable, a patient can, if any emergency surgeries, temporary pacing can be done. Then coming to Wolff-Parkinson-White syndrome, which is a re-entry arrhythmia, accessory pathways between atria and the ventricles. If impulse arrives when main pathway is no longer refractory, this impulse passes around the circuit repeatedly, activating it. In ECG, we have a feature of short PR with the PR interval with a premature slurred R wave, that is a delta wave. We can go for our manuals. Flecnite 50 to 150 milligram IV, propanolol 1 to 10 milligram IV, or diazopyramide 50 to 150 milligram IV can be given. Also, DC cardioversion can also be done in definitive therapy for WPW syndrome is ablation therapy. Then coming to broad complex arrhythmias, ventricular ectopics, which is usually benign in absence of structural heart diseases. It's usually self-limiting unless we also can go for treating the reversible causes. Then coming to ventricular tachycardia, which is a high from the ventricular muscle. Usually the heart rate will be more than 100 beats per minute with a widened QRS. If AV dissociation is present, P wave may be seen with the capture or fusion beats, like in RBPP patterns. Intra, we need to exclude the hypokalemia and hypomagnesemia because patients on dietary therapy usually have this electrolyte imbalance. Correcting this minimizes the risk following the arrhythmias. And other causes like MI, hypoxia, hypotension, and fluid overload will also be there. Management, we can divide into either it's stable or unstable. In ventricular tachycardia, if the pulse is present and patient is hemodynamically unstable, we can go for a synchronized cardioversion at 150 joules, rising up to 360 joules biphasic if needed. If it is hemodynamically unstable and pulseless, we can go for a CPR. We can go for a CPR and direct cardioversion as a priority. If the patient is hemodynamically stable, we need to correct the reversible condition. And when we are trying to correct abnormalities, we need to take 12-lead ECG before and after correction, so we can go for a comparison. First line drug, amiodarone, which is 300 milligram IV over 1 hour, and followed by a 900 milligram over 23 hours. If it is an SVT with the bundle branch block presentation, we need to go for adenosine. So drug of choice differs in both of them. This tachycardia can be divided as sustained or non-sustained. If it is sustained, we can go take it as a monomorphic or polymorphic VT. If it is non-sustained, like more than 3 premature ventricular contractions at a rate of more than 120 beats per minute, lasting for more than 30 seconds without hemodynamic compromise. Other drugs for VT, like we can go for lignocaine 100 milligram IV, followed by maintenance infusion of 4 milligram IV, gradually reducing the dosage. And this reverts to sinus rhythm in 30 to 40% cases. Also, we can choose milligram IV over 5 minutes, procainamide 100 milligram IV over 5 minutes, followed by infusion and electrical cardioversion. Then comes relation, fast, chaotic, and disorganized broad complexes on ECG will be there. There will be no pulse due to the lack of cardiac output. We need, before diagnosis, AF with the atrioventricular accessory pathway, effect from diet and stuff, and the patient, if the patient is moving enough. Early electrical defibrillation should be done. Non-symptom initial biphasic shock with 150 to 200 joules and slowly can be raised to 360 joules for subsequent shocks. If the we is in a cath lab, we can go for 3 consecutive shocks, like it can be called as a stacked shocks. If no defibrillator, we can go for a CPR and oxygen and ventilating the patients with 100 compressions per minute and protecting the ABC. And go for adrenaline 1 milligram IV or intraosseous every 3 to 5 minutes. We can treat this as we can treat this similarly like a pulseless VT management. We not treat all the reversible causes. Coming to Torsades, atypical polymorphic VT with a beat to beat variation. QT is prolonged QT and constantly changing or twisting QRS axis around the baseline. Here the management is ideally we need to eliminate the cause, whether a drug-to-drug interactions or a metabolic corrections or anything. Magnesium 2 gram as an emergency cellular membrane stabilizing drug can be given. And if unstable, we can go for a cardioversion. We also have a conduction disturbances like bundle branch block, RBBB, LBB. RBBB pattern is usually physiological and it's benign. Sometimes it can be it can turn into a chaotic scenario. The presentation of LBB will be a QRS prolongation with monophasic broad R wave in inferior leads with a poor R wave progression. and we can see a inversion due to the fundal bunches. Then coming to heart blocks, first degree is usually a PR prolongation. PR prolongation of more than 0.2 seconds. This is usually asymptomatic, and it might progress to second degree AV blocker. If symptomatic, phasing can. Coming to second degree blocks, Mobitz type 1 and type 2. Mobitz type 1 with its Wenke badge. Here we have a progressive PR prolongation and failure of conduction of an atrial beat. It's usually asymptomatic, but the risk of developing into 2 is and if the patient is symptomatic, we can go for pacing. And Mobitz type 2, this is also concerning because it can progress into a third degree block. Third degree complete dissociation between atrium and the ventricle side. So there will be no conduction from the AV node. We can divide it as to either this impulses from above AV node or below AV node. If it is above the AV node, ventricles revert to the rate of 45 to 50 beats per minute. And if it's below AV node, this presents with the rate of 30 to 40 beats per minute. Atria continues to beat independently at a different and higher rate. Management is 100% oxygen. Atropine trial can be given, or isoprenylene infusion can also be started. Followed by transcutaneous or transvenous pacing can be done. And in all these cases, if symptomatic, we can go for a pacing for going for surgery.
So completed?
Yes, sir.
Okay. This is more or less like what you are described or presented is just enumerating all the various types of arrhythmias that are commonly given in a textbook. But the question that is asked is common intraoperative arrhythmias and their management. That is the question. You should avoid verbatim repeating all the arrhythmias that are given in the books, because under anesthesia you commonly see VPCs. Did you talk about VPC?
Yes, sir.
That is sometimes innocuous, sometimes when it is persistent. Before you said sustained ventricular tachycardia may appear as a VPC. Okay? And atrial arrhythmias are more common. And of course, the conduction blocks are quite rare in the intraoperative period unless there is a myocardial infarction involving the pathway. Conduction blocks are not very common. And there can be VT, defibrillation are much more common than the other types of arrhythmias. So the emphasis should be on common arrhythmias that occur under anesthesia and the causes for them, like traction on the viscera, stretching of the peritoneum, or dilating an orifice. So all these things may be the triggering factors for all these things. And there is always a difference between a patient already having a cardiac arrhythmia coming for surgery and a person with surgery and then developing an arrhythmia intraoperatively. Okay, so that sort of differentiation should be there. I'm getting a signal of low battery in my headphone, so I'll just rush through the preparation that I have made so that